Now, we're going to hear from a regional presenter. So Kate Hopner's got a very interesting title for her presentation. When I was a medical student and young doctor, I thought OVA was something to do with the plural of ovum, which was something to do with fertility. But now we have a new acronym in health, which is OVA, Occupational Violence and Aggression. So Kate is going to talk to us about a prevention strategy at the La Trobe Regional Hospital. Thank you, Kate.
I wanted to have a snappy title so that you would be interested. Thanks very much for asking us to present today. Just in terms of, I guess, a bit of context, La Trobe Regional Hospital is the major referral hospital in Traralgon, in Gippsland, 289 beds. We also provide the area mental health service for Gippsland as well, very large service from Phillip Island up to the New South Wales border. So in terms of transfers into LRH, we have between 10 and 12 EDs and urgent care centres that would transfer into our emergency department. So it's good to keep that in terms of context. In 2013, we set up our Occupational Violence and Aggression work group late in the year and established that with representation from a broad range of stakeholders. So I'm the chair. We also have another person on our executive that's on that committee. And we have a range of staff, frontline staff, union reps, safety, security, clinical staff, our co-directors of the emergency department, both sit on that committee, and representing mental health, allied health, right across the spectrum of services. So we got together and thought, well, what is it that this group is actually going to do? And our main focus was to reduce the impact, the frequency and the impact of occupational violence and aggression in our workplace. So where did we start? We did a lot of thinking, and what we actually wanted to know was, we wanted to know what our staff thought about occupational violence and aggression, and we wanted to know where our high areas of risk were within the organisation as well. So we actually conducted a risk rating using a risk matrix of all of our departments as a starting point, and I'll talk a little bit about that shortly. We also conducted a workplace violence staff assessment survey, and I will focus on that a little bit later as well, but that gave us some really very interesting information around staff perception and what was actually happening in our workforce. Once we got all of that data, we fed back those risk ratings and staff assessment responses to our staff groups and our senior manager forums and created some discussion amongst the broader staff group. We also used a self-assessment tool and looked at the emergency department, which was where we had a lot of our code greys and aggressive incidents. So we actually walked through and did a self-assessment of the environment, policies, procedures and training as well. And of course, we looked at all of our incident data, injury rates, codes, our seclusion usage and our restraint usage across the service as well. In terms, we kind of captured that information and then looked at some of the frameworks and evidence that was around. You know, we need to look at good practice, best practice. Sue's mentioned, you know, don't reinvent the wheel, look at what other people are doing. So we went and had a look at a number of things, and we'd been doing quite a bit of work on reducing seclusion and restraint. So we had looked at quite a lot of data in that sense. The Task Force on Violence in Nursing, ANMF plan, the Auditor General's report, a lot of research, literature. But we also looked at the Workplace Violence Prevention Toolkit, which is the Emergency Nurses Association in the United States. So they have a toolkit that they use, and it's got a range of tools in it that we have adopted and adapted in our area. So and I'll talk a little bit more about some of that. So there were the frameworks and evidence that we looked at. This is our initial risk rating for the departments, and the interesting results from some of the areas in terms of how people rated extreme risk, high risk, moderate risk and low risk. And apart from the fact that, I guess, you know, it's not a foolproof kind of risk rating, but what it said to us is there's widespread violence in our workplace. People are experiencing verbal abuse, physical abuse, threats, all across our organisation. So we knew that it was a significant issue. In terms of our staff survey, sorry, that's not the best kind of shot of that in terms of reading it. We sent out a survey that we got through the Emergency Nurses Association Workplace Violence Toolkit, slightly adapted that to our context, and we actually sent that out on SurveyMonkey to all of our staff. And we had 105 staff complete that survey, which we thought was actually not too bad. Out of those 105 returned, 71 of our staff had never attended any workplace violence prevention training, or they hadn't attended it within the last 12 months. So a very big chunk of people hadn't been to any training. Almost 50% of our staff didn't report workplace violence. Again, we know that it gets underreported. And 89% of our staff thought that most violence wasn't reported, which goes with the literature and anecdotally what we see. In that survey, our staff reported that they'd experienced 363 experiences of aggression in that previous year. So either being harassed, sworn at, shouted at, or racially abused. 6 were threatened, and 371 episodes of physical aggression, whether it be kicking, biting, hair pulling, scratching, being pushed. So our staff are telling us anonymously in a survey that this is going on, but it's not being reported. The majority of our staff wanted training in how to talk to people and de-escalate and negotiate and try to work with people to recognise early warning signs and manage aggression, which goes, I guess, without saying, because most of our staff hadn't actually had any training, and that's what they wanted. They did talk about what they thought were the effective ways of controlling aggression or managing people with aggression, and there was a lot of feedback around having person-centred care models, having really good emergency codes. Mental health and alcohol and drug issues came up as a huge factor, which we know, and having really good de-escalation training. So then after that, we got together as our work group and we came up with our Occupational Violence and Aggression Improvement Plan. So this is our current plan, and we review this annually, and we review it at each meeting when we meet and go through all of our interventions. So that's just a snapshot of the plan. It's got 3 strategies. I've just shown you the first page there. One is to raise awareness across our staff group, but also our local community as well. The second strategy is building knowledge, competency and skills. And then the third is responding and taking action to create a safe environment. So there's a number of key actions and interventions underneath that those action plan strategies. I'm going to, I guess, reinforce what Sue said earlier around having board oversight and CEO and executive involvement. You can't make these things happen if you don't have your board and your CEO and your executive engaged and leading from the front. And that's where our program sits. We have oversight to the board. I report to the board monthly in my report. We have executive buy-in. We have our managers buying in. I often hear that, as I talk to different groups, that managers don't care or managers aren't involved. Well, I think that there's evidence that there's a lot of management involvement in a lot of occupational violence and aggression reduction programs, and it's the same for us. We have very senior management buy-in and our executive and board as well. We've got managers on our work group. We of course have occupational violence on our risk register, so it's a strategic risk that we review and monitor. And we have the OVA work group reports through to the Occ Health and Safety Committee, quality committees and to the board ultimately. One of the first things we did was actually change our policy in terms of occupational violence and aggression. We had the old zero tolerance, we'll have zero tolerance policy, and we reviewed that, and we wanted to make that focused more on setting a high level of governance, but giving a high level of advice to our staff around how to manage occupational violence and aggression. So again, this has come from the research literature and looking at other programs that have happened internationally, and we use the STAMP model. I hope you can read that. So our policy reflects the STAMP model, our training reflects the STAMP model, and that's a card that we all have on our ID badges to prompt, to get people thinking and reinforcing what they're learning in the training. So the STAMP model is basically around recognising cues for violence and teaching staff how to recognise those cues and then how to respond. So that's how we're focusing our training and setting our policy framework. Prevention comes first. In terms of prevention, and I don't want to kind of keep repeating what Sue said, but we do a lot of the same things in terms of really looking at our data and our incidents and what's happening, and really thinking around how do we identify themes, problems in systems, gaps, to actually make changes. So we have made a whole lot of changes to things like alerts policies, home visit policy. We review all of the themes from all of our codes and incidents, and that happens with the OVA work group. We implemented security roles into the acute mental health unit. So previously they just kind of roamed through, did a check and moved out. But when we analysed our data, we found that most of our code greys were happening in our acute psychiatric unit after hours. So we have put 7-day-a-week security coverage in our acute psychiatric unit on an afternoon shift, and we trained those staff, in addition to their security training, they were trained in de-escalation techniques, suicide intervention, mental health first aid and the safe wards. So the focus of their role is around being there constantly engaging, de-escalating, and that's proved to be a very successful intervention. The safe wards rollout, which we've implemented in our acute aged unit, our adult unit and our secure extended care unit, and we're having discussions around rolling that out and planning for a rollout in our critical care unit, who have high rates of aggression. So the safe wards, developed by Len Bowers in the UK, and he basically has 20 odd years of research in acute psychiatric units, and was able to identify all the areas of flashpoints where the conflict would be created, and then we would, as nurses, come in and do some sort of containing response, so whether that's medication or seclusion or restraint, and that's where people get injured. So the safe wards contains 10 modules, evidence-based, and it's around identifying flashpoints across staffing, environment, consumers, policies, and the whole purpose of the safe wards model is to reduce that conflict and containment, so that you're reducing aggression and then you're reducing those restrictive interventions. And we've worked with Peninsula and another 7 units that piloted that across the state, and there's a statewide evaluation of that shows that it is reducing rates of aggression and reducing rates of restrictive interventions. So a good evidence-based model that has potential to lift some of that work into general settings, and there's quite a potential for that to make some improvements. Our cognition work group, we implemented a delirium pathway. We found that we had a lot of people presenting in a delirium and becoming aggressive, so evidence-based delirium pathway implemented. Alcohol and other drug strategies were quite important for us. And as I mentioned, we have quite a number of emergency departments that send clients to our emergency department in Traralgon, and a lot of those people will have mental health and alcohol and drug issues. So we found people were presenting 2 hours away in Bairnsdale, intoxicated with ice. They were being put in an ambulance, restrained and sent to Traralgon, no treatment. All hell broke loose basically when they get to the emergency department. So early intervention is really, really critical. It's interested to hear your role around sending AOD workers out with the police. Significantly important that we actually do some interventions in that area. We did a whole body of work across our region and trained about 350 staff in other acute hospitals, EDs, emergency department physicians, GPs, quite a whole lot of people around ICE, how to manage people who present with ICE, sedation algorithms and treatment interventions, so that those staff feel more confident and competent to manage that at the point that the person presents, rather than waiting and the risk then escalating by the time they come into the emergency department. We also implemented an alcohol and drug nurse practitioner in the emergency department in Traralgon, and that has been a fantastic initiative in terms of not just education and support for the workforce in the emergency department, but that high-level specialist early intervention to manage people who are presenting with alcohol and drug use. And we're seeing some really good outcomes there. We also have things like security escorts to cars after hours for our staff so that there's safety after hours when they're leaving the premises. We developed a new policy with Bass Coast down in Wonthaggi, particularly around people who exhibit extreme violence and aggression when they present. And we've put a policy together with Bass Coast Ambulance Victoria, police and ourselves to actually manage people in the police cells with us all presenting there and managing that risk rather than bringing the person into the emergency department where things were escalating. So that's a new intervention that we've got in place. Peninsula Health has a PACER. We have a MAPPA, which is Mental Health and Police Response. So the same process. We have 2 sites in Wonthaggi and one in Morwell. Mental health clinicians on site. They work from the police department and they provide specific mental health support out in the community. And that has seen a reduction in codes. We've seen a reduction in transfers into our emergency department. We've seen reduction in code greys, so that reduces the risk. So that's a really good program that's had some really good outcomes. We also have emergency service liaison committees. So we meet every 6 weeks with our Ambulance Victoria, police, emergency department, security across the region. So all of the emergency departments across the region. We've got really strong relationships with those acute hospitals. And that is a place where we will review incidents, we'll look at high-risk patients, so people that are presenting quite frequently and posing a risk to all services. We'll put in place management plans to manage that risk. And we do a lot of joint training and development of policies, and so we often have police, ambulance, mental health staff, ED staff in training together, learning the same thing, so we have a consistent approach to training. And I think that for us in a regional area, that collaboration and that regional role and the links that we have with our emergency departments and police and ambulance, the relationship there is absolutely critical to the work that we do. In terms of training, a few acronyms there. DEEP, so that's our de-escalation, engagement and prevention training, which is mandatory for all of our staff. That's online mandatory training. And then our higher risk areas, so our emergency department, psychiatric units, they'll do a face-to-face training as well. We have a restraint leader training, so if you are the person in charge of leading that restraint, there's particular training for that team and particular training for the code grey team. We have a psychiatrist and a psychiatry registrar on our code grey team, and that is always led by the senior mental health clinician on duty, so it's a clinical-led response, and we have security support as well and medical support. Of course, we run our safe wards training regularly, and that's mandatory for anyone that works in any of our inpatient units. And we have regular and consistent alcohol and other drug training and alcohol and other drug practitioners within the higher risk areas to actually provide that supervision and coaching so that you don't just walk into training, learn the skills and then walk out and aren't able to implement. So we need to support that as well. Oh, there we go. In terms of responses to occupational violence and aggression and some environmental controls, we have our Code Grey and Code Black emergency procedures, a whole range of duress alarm systems and closed circuit TV systems. We do have a post-incident response for staff as well, so we have our employee assistance program that people are referred to, but we also have an internal post-incident response where we work with our managers to support staff individually, provide some watchful waiting and care in terms of how that person responds to that incident. All of our assaults and property damage are reported to the police, and that's something that we're very strict about. We also complete a Haddon matrix at each code, which I'll talk a little bit about later, which is part of the toolkit that the workplace violence toolkit in the emergency nurses have. So that gives us quite a bit of data. In terms of reporting, each area has what we call the knowing how we are doing board. So we demonstrate all of our quality and risk activities. and celebrate the good work that we do, and we put a lot of data on that so that visitors, patients, staff can see the data. So we have a monthly, what we call the OVA dashboard, and we put all of the information around codes, injuries, restraints, seclusions, those sorts of things on that reporting. We then report up to the Occ Health and Safety Committee through the OVA group. We send out regular updates to all of our staff, and we have an OVA update at all of our senior management and staff forums, and we have quite a complex database that captures all of the restrictive interventions across the organisation. Investigations. So all our OVA incidents have to have an initial investigation within 24 hours. We know that that's the best way that we can actually get in early, investigate and make sure that we put in anything that will prevent those incidents happening again. Everything's documented on Riskman. We do critical incident reviews for occupational violence incidents. We analyse the themes of our Haddon matrix, and everything gets reported to our Occupational Violence and Assessment Work Group. Just in terms of some examples, this is our code grey data from 2016. So we were at about 700 incidents of code greys in 2014, and we're down to around 350 last year. The red one is the silent code grey, and the blue is the code grey. So trending down, but we would like to probably see more use of the silent code grey in terms of planning and training, that people are feeling more confident to manage those. So we're still tracking our data quite intensively. That's just an example of some of our restraint data that we report on monthly to our units. And this, you probably can't see that very well, this is the Haddon matrix. So I'm not sure if anyone has looked at the workplace toolkit through the Emergency Nurses Association, but they use the Haddon matrix. It's used quite broadly, but it basically is used to identify factors that contribute to workplace violence. So looking at environmental factors, the person who's perpetrating the violence and the staff that are responding or working with the person. And then you think about a whole range of characteristics that are present before, during and after the incident, and it gives you a way of actually analysing the theme. So every code grey that happens, the Haddon matrix is completed by the senior person on duty, and then all of those are reviewed at our OVA meeting, and we look at all of the themes, and then we identify issues that need to be addressed. A lot of the time, the issues are around staff training, and sometimes systems issues and policy issues. So that's been a really good process for us to look at what our themes are in terms of OVA, and then how do we actually address them. Next steps. So where to from here? It is about commitment and leadership, and I think all of this work needs to be driven from boards, CEOs, executives, senior staff. We need to be all actively engaged in conducting this work. There's some good evidence and interventions from overseas and in other hospitals, so not one size doesn't fit all, and don't reinvent the wheel. There's lots of great things that you can take from other organisations to fit your own organisation and adapt that. Where we're heading next, we are going to look at conducting a OVA gap analysis, so a prevention of violence in healthcare audit tool that we've got out of the US, and it's quite comprehensive, so we're going to trial that in our organisation and look further to see where our next lot of gaps are, and start conducting that as an annual audit. We're going to repeat our staff survey and see that in the last few years if we've made changes, and if the staff perceive that we have actually made some changes, and really their experience of the work that's happened. We're also going to look at developing a broader people safety strategy, so not just about occupational violence or incidents of violence, but things around psychological safety, mental health and wellbeing, bullying and harassment, and look at how do we approach safety for our staff within the broader organisational context. We'll develop some new KPIs and look at expanding those in terms of reporting, and looking for innovation. So we've got a really great committed bunch of people in our work group a very engaged board and executive, and we're really looking at ways to be more innovative and learn from others to make more of an impact. And I think that's kind of the message, is it's complex, it's multifactorial, and there's no one solution. But I think with good leadership and commitment and the ability to innovate, we'll certainly see some improvements in this area. And that is the end for me. Thank you. Happy to take any questions.
Thank you, Kate. Can I invite questions from the floor or from our video conferencing participants? Anything coming through there? No? Okay. They are there though, aren't they? Yes, good. Does anyone have any questions of the experiences from LRH that Kate's presented? It was very comprehensive. We've got one? Oh, yes, over there. Thank you.
Thank you. Mary Whelan from Bass Coast. The MAPA project is working really well for us, as you've said. I'm interested in the, we know the traditional first aid training that people do in the community. I believe, but I haven't seen it, there is first aid training in mental health.
Yes.
Are you able to speak a bit about that and see where it might fit in as a start, maybe for community groups or services?
Yeah. I think that one of the difficulties is if you break a leg or you get a snake bite or something happens, someone will know how to give you first aid. If you have a mental health crisis, often people don't know what to say or how to manage that. And I think there's definitely a role for mental health first aid to play in early intervention and actually getting people into services earlier. So I think it's one component that can work. We've done some mental health first aid training across all of our manager group and our HR department, but we run it a lot for community groups as well. And the feedback is always fantastic that, why didn't I do this earlier? I would have known what to do. So there's definitely a role for first aid training in early intervention. Absolutely. Yeah.
Thanks, Kate. Any other questions?
No.
Okay, thank you,
Thanks.
Kate, very much for sharing that with us. Please thank Kate for her contribution.